Today we're going to discuss seizures and epilepsy. We're going to understand how seizures work and use that understanding of the underlying pathophysiology to make sense of how we're going to diagnose and treat epilepsy. And we're going to watch a couple of videos of different types of seizure semiologies. So first of all, I want to talk about what is a seizure. A seizure technically is usually described as a sudden disruption of brain activity caused by an abnormal firing of neurons. And it can give different symptoms depending on where localization of the seizure is. Different parts of the brain can have abnormal electrical activity, which would then give you a seizure with different symptoms in different places. Epilepsy is a disorder where you have a tendency to have more and more seizures recurrently and not provoked by anything. And that is all according to the ILAE, the International League Against Epilepsy. But what is a seizure? This definition never really did it for me as far as really understanding what is happening to a person's brain when they're having a seizure. So I want to use a case to illustrate exactly what a seizure is on a physiological, anatomical level. So we got a 57-year-old who's brought into the emergency room after being found down in his shelter, was brought into the trauma bay, and the patient was not speaking or interacting, really not being themselves. And then in the emergency room, he had a witnessed episode where his head turned and his eyes looked to the right, and then his right arm started to clench up in like a flexed position as if it's curled up into his body. And then both of his arms started to do that. His other arm, his left arm, came in as well and curled up into his chest. And then both of those arms started to twitch and then start to shake rhythmically over and over and over a few times a second. What is going on with this patient? And more specifically, what's going on that deeper anatomical level, that level of the neuron? This is a picture of a neuron. Here we have the cell body, and then we have an axon, and every axon has multiple branches. And we're going to look at this branch of this axon. This axon is synapsing onto another axon, right? So this axon terminal synapses onto this cell body of this neuron, and a new axon projects down to yet another neuron. This neuron, axonal branch, synapses onto a fourth neuron, and now we have created a simple diagram of a neuronal circuit. All neurons are part of circuits, and that's how they communicate with each other. We have different types of neuronal circuits. Some neuronal circuits fire on from one neuron to another, and we like to call those circuits, those intrinsic circuits that stay within the nervous system from one neuron to the other, as association networks going from one part of the cortex to the other. We have other types of networks that go from our cortex down to our muscles, or down up from our sensory organs, up our neurons, up to our brain. And we call those kind of networks projection networks. And we're not going to be talking about projection networks for right now. We're going to be focusing on these association networks. Networks of neurons that all fire from one onto the other, creating a complete circle. Okay? This is where seizures are going to be emanating from, and we're going to get into exactly how that happens. We're going to zoom in onto a synapse. So this is, the top of the synapse is the axon terminal, and it's synapsing onto the dendrite of a cell body of the receiving neuron. So this neuron is going to be sending a signal down with an action potential down the axon terminal, and then we're going to get the signal across the synapse onto the next dendrite to be able to transmit that signal. Inside the axon terminal, we have vesicles, and in this case, we're talking about a glutamate secreting neuron. So these vesicles contain glutamate, and these little diamonds that are green colored are representing glutamate molecules. Of course, let's introduce all the other characters involved here, and these are all important because when it comes time to treatment, this is how we're going to treat epilepsy, is by targeting each of these channels and each of these parts of the synapse. We have these voltage-gated sodium channels, which famously line the entire axon, and they're voltage-gated, meaning that when they sense electrical potential change across the membrane, that will cause one to open, and when that one opens, it will cause the next one to open because of that electrical change and cause that chain reaction to travel down the axon until it gets to the axon terminal. And then we have a voltage-gated calcium channel. That's going to be right here, and that's going to be how we change from this electrical voltage-gated signal into glutamate vesicle release. And we'll talk about that in 1 minute. Of course, we also have our glutamate receptors here, which are going to be receiving and binding to the glutamate as it travels across the synapse. And we have the snare proteins. These proteins live on the axon terminal membrane and bind and stick to the channels. So we have the sodium channels opening, and the voltage-gated calcium channel detects the influx of sodium. That electrical change causes the voltage-gated calcium channel to open. And when that calcium channel opens, the calcium floods in and signals to the snare proteins to bind to the vesicles. These vesicles will cleave and join with the membrane, allowing the glutamate inside of them to release. The glutamate will be released into the synapse, and then they will meander over and bind to the glutamate receptors. The glutamate receptors themselves are sodium channels. Instead of being voltage-gated sodium channels like up here, these sodium channels are neurotransmitter-gated or chemically gated sodium channels. They receive the chemical signal from the glutamate floating across and open up, and sodium flows through. This influx of sodium is an attempt to cause this receiving neuron to propagate its own action potential. But as you can see here on this synapse that we've drawn, there are only 3 sodium ions that flow through. And in this illustration, we're going to need a little bit more than just 3 sodium channels to reach that membrane potential that's going to get us to open up the the voltage-gated sodium channels in the receiving neuron to propagate the action potential. 3 is just not enough. And it might require the input of a few glutamate neurons all simultaneously firing on this receiving neuron in order to make this one fire. But something special happens. This isn't the end of the story for these glutamate receptors. Notice this little extra protein that's attached to the glutamate receptor. This is a G protein. A G protein, when this sodium channel, this glutamate receptor, changes conformation, is released and floats down to the nucleus of this neuron. Of course, the neuron's nucleus contains its DNA, and that G protein signals to the nucleus to create more glutamate receptors. So now instead of 3 glutamate receptors, we have 4. Okay? This process in biology is called positive feedback, or in molecular biology is called upregulation, right? So the signaling of glutamate and the activation of glutamate receptors leads to the creation of more glutamate receptors. That is positive feedback, right? So when we traverse the synapse and glutamate bound to the receptors, that signals the creation of more glutamate receptors, so that the next time that this axon terminal receives an action potential and signals the release of glutamate vesicles, glutamate will bind, and instead of opening just 3 sodium channels, we're going to open 4. And now that signal is stronger, right? Every time this synapse is traversed, now it sends a stronger signal. And that process of strengthening the signal again and again until this synapse is very powerful, right? Now, each time this synapse fires, it could potentially signal and tell this receiving neuron to fire all by itself. This process of strengthening synapses is called long-term potentiation. Long-term potentiation is how we learn and how we form memories. And this is also how seizures develop. Because if you can imagine, if we potentiate this synapse, and that leads to the potentiation of this synapse, and that leads to the potentiation of this synapse, and finally to this synapse. If we strengthen each of these synapses so much that each time one of them fires, it causes them to fire on the other, then you can see that we've created a loop of firing that cannot be stopped. And when we create a loop of firing that cannot be stopped because of this aberrant long-term potentiation of an association network, that is what we call a seizure focus. Imagine this seizure focus is firing on itself over and over and over, and sometimes at random, and sometimes if it's provoked to do so, this electrical spinning seizure focus can escape, and the electricity can escape out into other networks and generalize into larger parts of the brain. If that spread repeatedly happens multiple times a second for long enough, then that could be the start of what we call a focal onset seizure. So, just to summarize, synapses can be strengthened by long-term potentiation, by the upregulation of glutamate receptors. If the glutamate receptors upregulate enough that they have strengthened the connection between synapses all throughout an entire association network, then we've created a seizure focus where this network fires over and over and over upon itself. If that signal that's circling and firing over and over on itself repeatedly escapes and spreads to a larger portion of the brain over and over for more than 10 seconds, then we have created a focal onset seizure. And that is what happened in our case in the emergency room. We watched that patient have a focal onset seizure. Remember how it started with their eyes and their head turned to the right and their right arm clenching up? They must have had a seizure that started in the left cortex, around where the frontal eye fields and where the motor cortex is. And then eventually it spread to the other side of the brain and generalized. And then their entire body started to shake rhythmically at the rhythm of the escape from that seizure focus. The seizure stops after 30 seconds, and on exam, the patient is slowly waking up, but they're not speaking yet, and they're unable to move the right side of their body. So that's interesting. And what happens is that after a seizure focus in an area of the brain that was seizing is done seizing, eventually that electrical activity may and hopefully will stop. That area of the brain has used up all of its energy, right? All of the glucose that was once there helping it metabolize is used up. And so that area of the brain that was once hypermetabolic during the seizure is now depleted of glucose and is hypometabolic. Because of that, the patient can't move that side of their body or can't use that part of their brain. So of course, if the area of the left side of the left hemisphere's cortex was firing over and over, after the seizure, the patient won't be able to use the right side of the body. And in this case, it seemed to have involved the language areas so that the patient is not speaking either. So we have a phenomenon where after a seizure happens and there's too much activity for a period of time until the glucose can build back up into that area of the brain, we have hypometabolism, and we have a post-ictal syndrome where you can experience paralysis or loss of function of that part of the brain for a period of time. By the way, when you can't move half of your body, that looks a lot like a stroke, and so sometimes, and very often, we'll get a CT of the head and CT angiogram of the head and neck to make sure we're not dealing with a stroke, and that's what happened in this case. And then after 10 minutes, as we expected, the patient began to move the right side of their body again and started saying words and being able to speak. The seizure is over, and now the post-ictal period is clearing up as their brain regains its normal function. The patient was able to talk to you and reported drinking a half a pint of vodka daily until 2 days prior. Okay, so now there's a new wrinkle in this story. And now, because of this history, we're going to be able to introduce another type of seizure called a generalized seizure. Okay? So let's reintroduce some friends of ours. Here we have our model from before. Voltage-gated sodium channels, signaling the voltage-gated influx of calcium through the voltage-gated calcium channel, which signals the snare proteins to bind to the glutamate vesicles, and signals the release of glutamate onto their glutamate receptors. But now we're introducing another neuron. And instead of containing glutamate, these vesicles contain a different neurotransmitter. Now we're dealing with GABA. GABA is another neurotransmitter. GABA is typically thought of as the opposing force to the excitatory signal that glutamate vesicles give. And the reason why they are not excitatory but inhibitory is because the receptors that they bind don't allow a positively charged ion like sodium to flow in, but instead lead to the influx of a negatively charged ion, that is, chloride. And so you can see that we have reached this homeostasis, and this is the great homeostasis of the nervous system. We have sodium influx, typically released by glutamate binding, and we have chloride influx into a neuron, typically signaled by the binding of GABA to the GABA receptors. Glutamate and GABA are the main excitatory inhibitory neurotransmitters in our nervous system, and the reason why they are excitatory and inhibitory has nothing to do with the glutamate molecule itself or the GABA molecule itself or its structure, but rather because of the receptor that receives those neurotransmitters and the fact that the glutamate receptor allows a positively charged ion, allowing the action potential to reach its threshold, versus a chloride ion, the influx of a negatively charged ion, which brings the receiving neuron farther away from the threshold that allows an action potential. What happens in alcohol use? Alcohol, among many things, is a toxin that binds to the GABA receptors and causes the GABA receptor to also change conformation, allowing chloride to come in. It also increases GABA vesicle release and works in a few different ways to increase the amount of chloride flowing into neurons. And of course, as you can imagine, if you drink alcohol, it's not going to be affecting one particular neuron, but all of the neurons in our nervous system. There will be a lot of chloride channels opening everywhere in our nervous system. And this is going to lead to less action potential propagation everywhere in our nervous system, leading to the symptoms that we all know about related to alcohol. That is, decreased responsiveness to outside stimuli, decreased time of response to outside signals, and general sleepiness and suppression, essentially all of the phenomena that we experience as being drunk. Blacking out, the inability to form new memories. Of course, we can't form new memories, right? If we are balancing out all of these sodium channels so that chloride, because of the chloride influx, then the G protein can't release and we can't potentiate these synapses or strengthen them, right? If we don't have the firing of the action potential, then we're not going to have long-term potentiation. And so we can't form new memories with alcohol use. But what happens if you're using alcohol for a long period of time, every day, for weeks and months and even years? The chloride channels are being opened constantly, and our nervous system is not in a state of equilibrium. Yes, we have 3 sodium channels and 3 chloride channels, but if the chloride channels are open twice as often, then really, if we're counting up ions, we have 3 sodium ions versus, let's say, 6 chloride ions. That is not a balance that our nervous system can tolerate. And so our nervous system has a compensatory mechanism to overcome this imbalance. You might be somewhat familiar with it. Watch what happens to this chloride channel, this GABA receptor. A G protein is released, and instead of signaling the upregulation of these chloride channels are downregulated. Okay? So this is called a negative feedback system or downregulation. You may ask, why does the excitatory system upregulate and the inhibitory system downregulate? And the reason is, well, if you really think it out, if you didn't upregulate your excitatory receptors, then you wouldn't be able to ever have long-term potentiation, and you wouldn't ever be able to learn. And that is not selected for evolutionarily. And similarly, if you, every time that you had an inhibitory stimulus, you strengthened the signal of that inhibitory stimulus, you would also not be able to ever potentiate. And without long-term potentiation, we cannot live and grow and learn. And so that is not selected for evolutionarily. And that is why the excitatory signal upregulates and the inhibitory signal downregulates. Now, instead of having 3 sodium ions flow in, and when chronically using alcohol, 6 chloride ions flowing in, now we are closer to equilibrium. And if we continue to drink alcohol and continue to keep these chloride channels open, now we're going to continue to downregulate until, with continued alcohol, so we've reached a new equilibrium, right? Let's say these sodium channels are open, and each opening 1 sodium channel, but the chloride channel is open 3 times as often because of the alcohol keeping it open. Then now we've reached a new equilibrium. But what will now happen if someone suddenly stops drinking alcohol? If someone suddenly stops drinking alcohol after years or months or weeks of use, then this chloride channel, this GABA receptor, is no longer open 3 times as often as the glutamate receptors are. Now it's going to be open just as frequently. And suddenly, out of nowhere, we have an excitatory imbalance where the excitatory signal is suddenly 3 times as strong. So as opposed to when we had increased opening of the chloride channels initially and we experienced drunkenness, now we're going to suddenly experience the opposite of drunkenness. And that is the syndrome of alcohol withdrawal. A patient will begin to experience tremor, will experience anxiety, can experience hallucinations, seizures, and even hemodynamic instability because of that hyper-excitatory signal, right? And of course, what kind of a seizure would you get in this setting? This is happening in every neuron in the brain, and so of course, it would be a generalized seizure, okay? And so this is what a provoked generalized seizure looks like. This is why it's happening, because of this imbalance between sodium and chloride influx, an imbalance between glutamate receptors and GABA receptors. And this, by the way, is true for other types of generalized seizures like hereditary generalized epilepsy. Imagine if you inherit a mutation in the sodium channels so that they are open too frequently, then that child will experience generalized seizures not being provoked by any toxin or another. Coming back to alcohol withdrawal, what is going to happen? When this chloride channel opens less frequently, then our neurons can signal that imbalance of increased glutamate activity and decreased chloride activity, increased glutamate receptor activity and decreased GABA receptor activity, and so we can now finally upregulate the GABA receptors again and again until, after a couple of days of alcohol withdrawal, they have now reached a new equilibrium. So, back to our ED case. A patient with alcohol use disorder found down in shelter, apparently after having stopped alcohol use 2 days ago, and now having a witnessed seizure in the emergency room, which was focal in onset with secondary generalization, followed by post-ictal paralysis and aphasia. So, maybe we can surmise that this person had a seizure because the alcohol was out of their system and now they have an imbalance and now they seized. But what's the problem with what I just described? The problem is, as we said, with an alcohol withdrawal seizure, if this imbalance between glutamate and GABA is happening everywhere in the nervous system, they should have a generalized seizure. And this patient in the emergency room had a focal onset seizure. So we have to ask the question, is this a provoked generalized seizure? If it was provoked by alcohol and it was generalized, then we can say, okay, we know why the seizure happened. The patient was withdrawing from alcohol and they had, as we expect, a generalized seizure. But this is not true. Yes, it was provoked, but it was not generalized. And so, if it is either unprovoked or it was focal onset, then we need to find the seizure focus, right? That seizure focused of electrical activity firing over and over and over again. We need to prove where that electrical focus is, because if there is an electrical focus, then this patient is predisposed to having more seizures in the future. And if someone is predisposed to having more seizures in the future, we need to give them a medicine to stop that seizure from happening in the future. And that condition, where someone is having a seizure, is as predisposed to having seizures, is called epilepsy. This is the workup we're going to do. We're going to do an MRI of their brain. And notice this small asymmetry, and of course I don't expect you to be able to look at this and find it, but I'm going to point it out to you. Notice this part of the cortex, and of course is asymmetric with this part of the cortex. And by the way, right, the cortex, which is the gray matter that surrounds the entire cerebrum, right? This is where all of those cell bodies are. This is where the synapses are. The white matter, those are those long axons. But remember, this is not a disease of the axon. This is a disease of the synapse. And so the cortex is where injuries to the cortex or damage to the cortex or atrophy of the cortex is where seizures are going to come from. And that's what's going to predispose us to having epilepsy. If we had demyelinating lesions in the white matter, that's not going to give me epilepsy. But if you have atrophy of the hippocampus here and sclerosis of the cortex here and scarring, that is absolutely going to damage the synapses there, leading to restructuring of synapses, new long-term potentiation, and this creation of a seizure focus. Additionally, sometimes we don't find a seizure focus on MRI. We can use EEG to look for an electrical focus. We put stickers on the scalp of the patient, about 19 of them total. And if there is an abnormal electrical signal emanating from one area, then we can say, aha, even though we don't see anything macroscopically on the MRI, electrically I can prove that there is this focus right in this spot. And that's in the T3 area right here. That's the left temporal lobe, exactly where we saw that cortical degeneration, that cortical scarring in the hippocampus. And so we have evidence that this person has an electrical seizure focus coming out of that area of cortical abnormality. And so we can say that this person has epilepsy and that their seizure that happened today was provoked by alcohol withdrawal, but they are predisposed to having more seizures in the future. Things we learned from this case. The pathophysiology behind a focal onset seizure. We talked about the seizure focus that is created by the strengthening of those intrinsic neural networks or association networks through the process of long-term potentiation. We talked about the pathophysiology behind general onset seizures, which has to do with that general imbalance between excitatory and inhibitory ion channels. We talked about seizures being provoked versus provoked and generalized, provoked and unprovoked, generalized and focal. And if a seizure is provoked and generalized, then we don't need to look for an underlying seizure focus. All we need to do is stop that provoking toxin, whether that's the alcohol withdrawal or whether it's an infection or cocaine use, whatever that provoking thing is, all we need to do is get rid of it, and that person should never seize again. But if the seizure was unprovoked or focal onset, then we need to search for a seizure focus using MRI and EEG. If someone is predisposed to having seizures, then we say that they have epilepsy. And EEG is trying to capture any of those signs of cortical irritability, those little sharp waves in between seizures. Sometimes we can also use EEG long-term for about 24 or 48 or more hours in order to try to capture a seizure and see what it looks like on EEG. A second case, in this case of generalized tonic-clonic seizure, is going to be helpful in talking about the medications that we can use. This patient has a history of diabetes and dementia, lives at a nursing home, and mostly performs their own ADLs. They can get dressed, activities of daily living, they can get dressed and bathe themselves. They've been sick, nauseous, vomiting, unable to eat well, and now this morning were found to have generalized convulsions. Their blood glucose was 651, and that's enough to provoke a seizure. But when we examine them, it looks like their arms were flexed and their eyes were fixed to the left. The fact that their eyes are fixed to the left makes me worried about this patient having an underlying seizure focus. Okay? Now, the patient has been seizing for 20 minutes. What's going on? If someone is seizing for 20 minutes, then they've reached a new severe form of seizure, which we call status epilepticus. Imagine if that seizure focus, right, is firing and the escape of the electrical activity is firing and causing the entire brain to have this rhythmic electrical activity, right, for more than 5 minutes, then they have reached this state of status epilepticus. Why is status epilepticus so dangerous? First of all, that repeated electrical activity can damage those neurons if they fire too much. And second, each time these neurons fire, what's happening? We are going through long-term potentiation and strengthening that synapse. So the more seizures you get, the more seizures you get. And the more you seize, the stronger and harder to treat those seizures will become. That's why it is our imperative that if someone is seizing for more than 5 minutes, we need to stop it immediately, and they reach this state of what we call status epilepticus. which forces our hand and makes us need to stop the seizure focus from spreading and firing. By the way, if a seizure, the definition of status epilepticus is either a continuous seizure for 5 minutes, or it could be shorter seizures, but if the patient doesn't return to their normal cognition in between the seizures, if their postictal syndrome does not clear up between the seizures and they keep seizing, then that is also considered status epilepticus, and we have the imperative to treat. So, how do we treat seizures? Remember, this is a disease of the synapse, and so let's look at the synapse and look at different places that we can treat these seizures. Let's look at some drug targets and develop some new drug classes. Well, of course, let's go in order. The way that the signal gets propagated is because of these sodium channels, these voltage-gated sodium channels. And so if we were to block them, decrease the likelihood that the action potential gets down, then that would be a really effective way of treating seizures. Next, we of course have the voltage-gated calcium channel that receives the voltage gate changes as a signal to open, which leads to the vesicle release. If we block this voltage-gated calcium channel, then we could be really effective in stopping the release of the glutamate receptors, right? Of course, the snare proteins are the next in line, and if we block the snare proteins from cleaving to the glutamate vesicles, then the glutamate can't be released. And that would be another really effective mechanism of action for a drug to have that would be able to stop seizures. We, of course, then could bind to the glutamate receptors so that even if glutamate binds to them, they won't open and cause sodium channels to open and stop the propagation of the action potential to the oncoming neuron. And finally, we have GABA. If we make GABA more powerful and stimulate those GABA receptors, then we could then we could stop the action potential from being propagated. So these are our 5 mechanisms of action that we have. We can have sodium channel antagonists, we have calcium channel antagonists, we have snare protein antagonists, we have glutamate receptor antagonists, and we have GABA agonists. And those are our mechanisms of action. So we have a few mechanisms of action here, and we'll talk about different drugs that fit into each of these drug classes, each of these mechanisms of action. So we have carbamazepine, lamotrigine, and phenytoin are 3 examples of sodium channel blockers. Ethosuximide is an example of a voltage-gated calcium channel blocker, and it specifically works in thalamic or T-type calcium channels, but don't worry about that yet. We have lorazepam and all other benzodiazepines, phenobarbital and all the other barbiturates, as well as propofol, which is a powerful anesthetic, all of which modulate and increase the amount of GABA signaling onto the GABA receptors, right? And they bind to the GABA receptors and increase the amount of chloride that flows through. Valproic acid, as well as propofol here, have multiple mechanisms of action. Valproic acid can bind to the sodium channels, blocking them, binds to the calcium channels, and also increases GABA signaling, in this case by decreasing the recycling of GABA, but in the end having the same effect of increased GABA tone, causing increased chloride channel opening. Propofol blocks sodium channels and also binds to the chloride channels and allows them to open. Topiramate is another drug that has multiple mechanisms of action, including calcium, sodium binding, and GABA receptor activation, and levetiracetam binds to our snare protein, specifically the SV2A protein, which you'll see in the next slide on the chart. This is another schematic that I find helpful when I'm trying to wrap my head around the different anti-seizure medications: sodium channel blockers, calcium channel blockers, glutamate receptor blockers, and GABA receptor agonists. We can make a nice triangle here, and we can put the drugs closer to where their mechanism of action is. Carbamazepine, lamotrigine, and phenytoin are going to be far in this corner. Lorazepam and phenobarbital are going to be far in this corner. Ethosuximide is going to be our main calcium channel blocker. Valproic acid, and again, this is why I like this schematic, valproic acid is in the middle of this triangle and has all three of these activities. Topiramate in the middle of this upper triangle and has activity with all three of these. Propofol has some GABA and glutamate, and so is up in this corner. And separately, but down by the calcium, because that reminds me that they both work at the axon terminal, right? The calcium channel tells the snare proteins what to do, and so I like to put levetiracetam in my schematic down here. Okay, and so as opposed to the prior slide, which showed each of the drugs with their mechanisms of action in the context of the synapse, I like this schematic because I can just remember that valproic acid is in the middle and therefore has all three mechanisms of action. Topiramate is in the middle, has these three mechanisms of action, and propofol is on the side, has the two mechanisms of action. So it's a more spatial way of memorizing the mechanisms of action of these drugs. These are tables with the drugs that you're required to know for our examination and for step 1. And you can come back to this and look through it in detail. The mechanisms of action determine the colors of the cells. Many are metabolized in the liver. Only a few are metabolized in the kidneys or excreted in the kidneys. This will tell you which ones are inducers of the P450 or inhibitors of the P450 system in the liver. These are their uses. Many are used for epilepsy, of course, but some are used for other uses like bipolar disorder, which you'll talk about in psychiatry, trigeminal neuralgia, which you'll talk about later in this course. And here are important adverse effects, both to the person who's taking it and to a potential fetus. So teratogenic ones are labeled here. And this is a continuation of that table. And you'll see valproic acid is the only P450 inhibitor, and the rest are inducers. And you can see that topiramate and levetiracetam are renally excreted as opposed to everything else that is excreted in the liver. So you'll take some time to absorb this, but this is a great summary of all the medications. Revisiting case 2. The patient received 2 milligrams of lorazepam intramuscularly by EMS, the Emergency Medical System Service, before they got to the emergency room. Lorazepam, remember, is a benzodiazepine, which is blocking GABA. So we have that mechanism covered. But the patient continues to seize. Let's block the snare proteins from allowing the glutamate release. The patient receives levetiracetam in the trauma bay, and still that's not enough. So we've hit GABA and we've hit the snare proteins. We're going to add on phosphenytoin, which is an IV form of phenytoin. And now we're blocking the sodium channels too, right? We're hitting this seizure from multiple sides to try to stop the status epilepticus from continuing and strengthening the seizure and causing irreversible neuronal damage. Finally, the patient is intubated so that we can start them on propofol, which is also, as we said, works with blocking of GABA and also blocks the glutamate receptors, and now we've really blocked almost all possible mechanisms here. And the propofol is a potent anti-seizure medication that we reserve for last line because it requires intubation because of the side effect of respiratory suppression. The patient is titrated up until their EEG pattern is suppressed, and they went from this rhythmic pattern here 2, being flatlined on EEG, which is what we're trying to do when we give them propofol. Aborting the seizure, stopping that seizure focus, and then, once the propofol comes off, they return to their normal rhythm, no longer in status epilepticus. Things that we learned from this second case. We talked about how a seizure can develop into status epilepticus. We talked about treatment of seizures as a disorder of the synapse. We talked about understanding different anti-seizure medications and why we use them, and their different mechanisms of action. And we talked about use of sedation with propofol as a potent anti-seizure medicine to control cortical activity, and the need for intubation because it's such a potent sedative. I want to end with 3 video cases, so that you can see what seizures look like. And the patients in these videos have given consent to share with medical trainees. These are patients who are on long-term EEG monitoring, and they were being observed in the hospital, which is why we were able to capture them on video. We're going to watch the semiology of the seizures, meaning what it physically looks like, and we're going to try to localize and decide if these are generalized seizures or focal onset seizures, and where the seizure focus may be. This is the first video. This is a young girl, and you see that she's blowing on this little spinning wind thingy. I forgot what these are called. Anyways, and she is blowing on it, and that hyperventilation is inducing a seizure. Watch her eyes flickering, and notice on the right side of the screen that she's gone into rhythmic activity in her brain and then suddenly returns to her normal activity. Okay? This is a classic absence seizure, where she stared off and was blinking for only a few seconds and then immediately returned to her normal without a postictal period. She's in the right age group, 5 or 6 years old, stared off into space for about 10 seconds, and then returned rapidly to her baseline cognition. The EEG showed a classic pattern, which is pathognomonic for absence seizure, which is a 3 Hertz generalized spike and wave. So note this line down the middle divides this into separate seconds, 1 second and a second, and you can count the amount of spike, waves, spike, waves, spike, waves, and this patient is experiencing a generalized seizure affecting all of the leads on the EEG on both sides of the brain. It is also able to be provoked by hyperventilation and also by photic stimulation by flashing lights, which is why sometimes you will see some warnings on certain television shows warning people about photic stimulation. Photic stimulation can synchronize cortical activity and provoke a seizure in certain types of epilepsy. Here's another video. This guy is sitting in a chair. We're watching him on EEG. He has leads on his head. And now he says, "I feel it coming." And he can feel a rising sensation in his stomach and a metallic taste in his mouth. You start to see that he's having a little bit of automatisms with his head, shaking his head. And notice his hands. He's doing a little bit of hand wringing, right? Scratching himself. And now picking his mouth. Now look at his right arm. It's starting to clench up. Meanwhile, he's continuing with those more complex behavioral automatisms. And now his arm is really clenching up out of his control. At this point, he is no longer aware. The nurse was at the bedside asking him to name the object, and he couldn't name it. And now his head is turning to the right side, the same side as the clenching is happening. The left side of his hemisphere is activating abnormally and clenching his right arm, making his head turn to that side. He looks very scared, and it's not because he knows what's happening. It's because it's possible that his hippocampus and amygdala are being activated, right, which are giving him a very basic fear response as part of the semiology of his seizure. He's looking up and to the right because those frontal eye fields in the left hemisphere are pushing the eyes towards the right side. And now things are calming down. The nurses didn't try to hold him or stop him. They allowed him to have the seizure, and they were just making sure that he was safe and protected with the pillows on the sides. This automatisms are slowly slowing down, and the seizure has evolved and is stopping spontaneously. This is a classic temporal lobe seizure. It's preceded by an aura of belly rising and metallic taste in the mouth. It's followed by a loss of awareness where the patient stopped answering questions. We noted that there was right arm and head tonic movement, tonic meaning staying in one position without shaking. And there was also right gaze deviation, all of this pointing to a left hemisphere cortical focus. There was some automatism touching the mouth and the nose, and our medial temporal lobes are really important in behavior and emotional response, and so a lot of the movements that he was having weren't rhythmic, simple movements, but more complex movements, which happen in seizures of the frontal lobe and the temporal lobe. There was post-ictal confusion, where it took him a while to remember what was happening and be aware of what was going on around him. Notice the bedside care. No one tried to restrain him, but they also didn't let him fall from bed, protecting the head of the patient and making sure that they don't hurt themselves. There was continued assessment for his recovery of awareness. And this is the same MRI that we showed in the second case, in the earlier case, and you see that his temporal lobe here has some sclerosis and scarring in the hippocampus, which would give a very similar seizure to what you just saw. This is the last example. This woman is talking to the nurse at the bedside, and then suddenly, in the middle of her conversation, she has behavioral arrest. She stops. And you're going to notice that she's going to start to look at her hands. They're going to start to shake. Just a jerk. Another jerk. Another jerk. And then, suddenly she's lost consciousness, and both of her arms are jerking non-rhythmically, which is what we call myoclonus, non-rhythmic jerking. Then she turns into tonic posturing, where the arms are not shaking, and then slowly turn into clonic shaking, where there is rhythmic shaking. So we had 3 types of movement, right? And again, remember, it was on both sides, so we would say that this was a generalized seizure, and it started with myoclonic activity, then turned into tonic activity, and then clonic activity. So something that you will hear very often is a generalized tonic-clonic seizure. You just saw one, and this is what it looks like. When we talked about seizures provoked by alcohol use, this is what they look like, a generalized, typically tonic-clonic seizure. It started as a generalized motor seizure with myoclonus. Something that you couldn't hear on the video was an ictal cry, where the diaphragm tightens up, and so air is pushed out of the lungs, and so it sounds like a cry as if someone is pushing air out of their lungs, and but it's not volitional. It's not the person doing it themselves. It's happening automatically without their control. Then they go into tonic posturing followed by clonic movements. It's important to make sure that the patient's airway is clear and controlled, and we want to avoid aspiration. It can be helpful to turn the patient onto their side so that if there is any vomiting, that they do not aspirate. And so it's helpful to turn the patient onto their side for that reason. JME, or juvenile myoclonic epilepsy, is a genetic epilepsy syndrome, or a heritable epilepsy syndrome, which involves multiple seizure types. They can have myoclonic jerking, like you saw, and they can also have generalized tonic-clonic seizures, very much like you just saw. And JME is a type of seizure that we're going to talk about in the team-based learning activity. It has a very specific EEG pattern called 3 to 6 hertz polyspike and wave, and they need lifelong treatment. Valproic acid is usually the most helpful for those patients. That's something that we're going to visit later on. Okay? Those are the seizure types that we're going to talk about. So I hope that this is a helpful foundation for when we do the team-based learning activity together.